Good afternoon, everyone. I welcome everyone on behalf of CCAMP this afternoon for the webinar that we have organized on vaccines and AMR. We have two speakers today. Let me start our session by introducing our very first speaker, Dr. Padmini Srikantiah. Dr. Srikantiah is a Deputy Director in Global Health at the Bill and Melinda Gates Foundation. She serves as the lead for the foundation's cross-cutting antimicrobial resistance strategy, which is focused on preventing mortality due to high AMR risk pathogens in low and middle-income countries, including efforts to prevent neonatal sepsis by developing a vaccine against Klebsiella. Dr. Padmini also leads the foundation's initiative to address respiratory syncytial virus, the leading cause of pneumonia in young infants globally, through the development of effective maternal and infant immunization strategies. So, and prior to joining the foundation, that is the BMGF Foundation, Dr. Padmini was with the US Center for Disease Control and Prevention as a senior medical epidemiologist, where she led the CDC's AMR platform in India, which encompassed efforts to strengthen AMR surveillance to reduce healthcare-associated infections. She also led the CDC's India infectious disease surveillance activities. Dr. Padmini has previously served as a medical officer for HIV treatment in the WHO's Southeast Asia Regional Office, where she led the HIV drug resistance surveillance and prevention program. Dr. Padmini is board certified in infectious diseases and serves in the CDC's Epidemic Intelligence Service unit. Dr. Padmini is from Seattle, and owing to the time difference constraints, she has specifically recorded this talk for us.
So, naghanap na ako saan. Sa India.
Good morning, good afternoon, good evening for all of you joining. First, thank you so much to the India AMR Innovation Hub for asking me to speak on the occasion of World Antimicrobial Resistance Awareness Week. My name is Padmini Srikantiah. I am a Deputy Director in the pneumonia programs at the Bill and Melinda Gates Foundation in Seattle. And I also serve as the Foundation's Antimicrobial Resistance Strategy Lead. Our AMR strategy has a primary focus on prevention of mortality due to high-risk AMR pathogens in low and middle-income country populations, and vaccines form a central part or pillar of that strategy. So today it's my pleasure to speak to you about the role of vaccines to reduce antimicrobial resistant pathogens. So as I think many of you have seen earlier this year in the report published in Lancet, the Global Antimicrobial Resistance Burden of Disease report, there are an estimated 4.9 million deaths associated with bacterial antimicrobial resistance globally in 2019. This makes this bacterial AMR the third underlying cause of disease in the global burden of disease level 3 causes, behind only ischemic heart disease and stroke. And with 1.3 or 1.27 million AMR attributable deaths, AMR is the 12th leading underlying cause of global burden of disease level 3 causes, which actually puts it ahead of HIV, TB, and malaria. Of course, many of you are also aware that the highest rates of deaths and the greatest number of burden of deaths are in low and middle income countries, which you can see on the figure here, where green is the regions in Africa and blue in South Asia. And those are the regions that are most directly and most significantly impacted. When we look at the top 6 pathogens responsible for the majority of these AMR attributable deaths, close to 1,929,000 deaths attributable to AMR, and over 3.5 million AMR deaths associated with AMR in 2019, there are 6 pathogens responsible for this: E. coli, Staph aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa. Of these, there are only vaccines currently available for one of these pathogens, Streptococcus pneumoniae. And then if we include also the seventh pathogen, Mycobacterium tuberculosis, there's also a vaccine, long-standing vaccine available for TB, although of course there are ongoing efforts for more impactful vaccines. So we know and we see this great burden of disease due to this antimicrobial resistant pathogens. And we also see that there is great potential for vaccines that could target these pathogens to help reduce these AMR deaths, as well as reduce antimicrobial resistance and antibiotic use. And why do we actually center so much of our strategy on vaccines rather than focusing on new antimicrobials, while acknowledging absolutely that the need for new and efficacious antimicrobials is paramount and important in the fight against antimicrobial resistance? We see that the time between deployment, between the first documented use of a vaccine versus an antimicrobial to the first documented resistance in humans due to resistance is much, much longer in vaccines compared to antibiotics. So while we know that there will be infections due to multi-drug resistant organisms that will require new and efficacious vaccine antimicrobials, as well as more judicious and appropriate use of existing antibiotics, we see that the use of vaccines has a longevity that is hard to beat. And that's part of the reason that we at the foundation are placing such importance on the potential of vaccines to address AMR. So I'm going to go back to March of 2017. Where there was a meeting at the Chatham House on the value of vaccines for antimicrobial resistance. And in this meeting, there was a clear understanding and discussion about the potential that vaccines can play to address antimicrobial resistance. But unlike the attention that had been given to prioritizing pathogens for new antibiotic development for AMR, there wasn't an equivalent list for a vaccine priority list. So many of the questions that came about were, how should the value of vaccines be attributed in the context of antimicrobial resistance? There was a clear need articulated to model that impact of vaccines on antimicrobial resistance, and key pathogens that were actually discussed. Many of them, including tuberculosis, Staph aureus, Pseudomonas, and Klebsiella, are in the top 6 pathogens that were outlined in the global burden of disease estimates. But there are also other pathogens for which resistance in and of itself may not be a huge issue, such as Strep pyogenes, or even viral pathogens such as influenza and RSV, but that antimicrobial use actually is a huge component of what drives treatment for these pathogens, and vaccines for these pathogens might have an impact on indiscriminate antimicrobial use. So we actually thereafter have, at the foundation, developed 2 different partnerships. One with WHO to really support the establishment of an initiative on vaccines to address AMR at the World Health Organization, and to help prioritize and develop a vaccine attributable framework for AMR. In addition, we have supported the Center for Disease Dynamics and Economic Policy, which is now known as the One Health Trust, to form a consortium of modelers that they called ARVAC, Antimicrobial Resistance and Vaccines Modeling Consortium, to quantify the potential impact of vaccines against antimicrobial resistance for a number of So subsequently, we have seen in the last couple of years, after our initial engagement with WHO in 2018, that WHO in 2020 came out with an action framework on vaccines to address AMR. And on this pictorial on the right, you can see this nice graphic that shows that vaccines, of course, protect individuals directly, but they can also decrease infections overall by their herd immunity potential in some pathogens, as well as reduce the incidence of resistant pathogens or resistant disease. And this subsequently can lead to the decreased use of antimicrobials and suppress resistance evolution, which both can allow decreased risk at the individual levels and enable antibiotics to be used effectively for longer. In addition, we know that some of these vaccines can also help reduce secondary infections, particularly those for viral pathogens where secondary bacterial infections may be a significant concern. So within the next 20 or so minutes, I'll be focusing on a number of pathogens and data. And strategically, the framework that we're using is the impact on both AMR burden as well as antibiotic use is demonstrable for existing vaccines that target AMR bacterial pathogens. So this includes pneumococcal conjugate vaccine, for which I'll share some data, and more recently, typhoid conjugate vaccine on resistant Salmonella typhi, and in the case of pneumococcus, penicillin non-susceptible Streptococcus pneumoniae. Vaccines may also reduce bacterial infections where resistance is not major, but that they may drive antibiotic use, significant antibiotic use, such as with group B Streptococcus, where there is widespread intrapartum antibiotic prophylaxis, as well as group A Streptococcus, where if a vaccine could be made, could reduce antibiotic use for skin and throat infections. I will not be sharing too much data on these two vaccines, but I will, however, also focus on the impact on antibiotic use of existing viral vaccines, measles, influenza, rotavirus, and then now RSV, for which we have some data from clinical trials, and now finally have some compelling data that are coming out for hopeful licensure of an RSV vaccine in the next year or two. And finally, I'll talk about new vaccines that could be developed to combat key AMR pathogens, focusing on Klebsiella pneumoniae, and in particular, the prospect of maternal immunization that could prevent and protect neonatal sepsis, or prevent neonatal sepsis and protect neonates in the first few months of life. So let's start looking at the data. So when we look at pneumococcal conjugate vaccine, I'll first look at data from the United States. And here is a paper from 2006 in the New England Journal, which showed that showed a clear reduction in pneumococcal invasive pneumococcal disease due to penicillin non-susceptible strains after the introduction of pneumococcal conjugate vaccine. So on the figure on the left, when the vaccine was introduced in 2000, there was both penicillin susceptible disease as well as penicillin non-susceptible disease, shown respectively in pink and blue. And you can see very clearly this sharp decline in both penicillin susceptible and non-susceptible disease among children who are vaccinated under 2 years of age between 1996 to 2004. When we look at the figure on the right, we actually see that even though there was vaccination for pneumococcal conjugate vaccine in young children and young infants, there was a broader herd impact, including that seen very strikingly in those of older age, and in particular in purple in those greater than 65 years of age, where penicillin non-susceptible pneumococci started to decrease after the introduction of a pneumococcal conjugate vaccine in young infants, even in other age groups that have been significantly impacted previously. Data from California also showed this reduction in antibiotic use in the pneumococcal conjugate vaccine PCV7 trial, where antibiotic prescriptions were reduced by 5% in all follow-up starting at dose 1, and by almost 6% after the primary series. And PCV reduced the subset of second-line antibiotics by about 12% in all-time follow-up and 13% in the per-protocol follow-up. So in total, PCV prevented a total of 35 antibiotic prescriptions per 100 children vaccinated per protocol, which is quite a significant finding. A similar analysis in Finland also showed that in assessment of vaccine effectiveness against outpatient prescriptions of antimicrobial drugs recommended by the National Treatment Guidelines for acute otitis media in Finland in children who had received at least one dose of the study vaccine before 7 months of age. And what you see is actually in the figure on the left, a percentage, the vaccine effectiveness of the vaccine to reduce antimicrobial prescriptions by episode and by age group. And while the overall vaccine impact was on the range of 8 to about 15%, this result actually, because of the overall incidence of antimicrobial prescriptions and the overall incidence of these sorts of otitis episodes, this reduction would lead to over 12,000 fewer antimicrobial purchases per year in children less than 24 months in Finland. So we see these significant data both from the United States as well as Finland on pneumococcal conjugate vaccine. What about in other geographies outside the global north? So the pneumococcal conjugate vaccine was introduced in South Africa some years later in about 2008 or so. And in South Africa, PCV and P10 as well as PCV 13 reintroduction was associated with an 82% reduction in penicillin-resistant invasive pneumococcal disease in children and an 85% reduction in ceftriaxone non-susceptible strains. So we see similar trends in very different geographies. And similarly, the introduction of PCV was associated with a reduction in antibiotic use due to the decrease in pneumococcal infections in and of themselves. More recently, one of the analyses through the AR-VAC consortium looked at the potential impact, the impact of PCV as well as rotavirus vaccines on antimicrobial use, focusing on low and middle income countries. And if we look at the figure on the left, the top half of the figure is focused on antibiotic treatment of respiratory infections, and the bottom half on antibiotic treatment of diarrhea. And what we see is on the left is a no vaccination scenario, and we see the incidence of antibiotic treatment of respiratory infections in the blue figure, and looking at low, middle, and upper middle income countries, and all LMICs in blue. In comparison, when we look at the number of antibiotic treated illnesses prevented under the current coverage rates in children under 5 for pneumococcal conjugate vaccine, we see that there's almost 24 million illnesses, antibiotic treatment illnesses, that have been prevented under the current 2018 coverage rates in children under 5 due to pneumococcal conjugate vaccine. If you then look at the final figure on the right half of the top part of the graphic, if we were to further expand coverage to pneumococcal conjugate vaccine to true universal coverage, that coverage would further decrease the incidence and the number, rather, of antibiotic treated illnesses in these low and middle income country geographies. So on the left, in blue is the incidence, and on the right in purple is the estimated total number of cases. If we shift our attention to the bottom half of the graphic, to antibiotic treatment of diarrhea, again, in a no vaccination scenario, you see the incidence of over 10 per 100 children, very frequent incidence of diarrheal illness. But if you look at the total number of cases of antibiotic treated diarrhea, in a no vaccination scenario, there's compared to a vaccinated scenario of current coverage, there's a reduction in 13.6 million antibiotic treated diarrheal episodes that can be associated or related to rotavirus coverage, rotavirus vaccine coverage. And again, if we expand this coverage to true universal coverage, this modeling estimate suggests an even further reduction in antibiotic-treated illnesses. And indeed, what they estimate is direct protection resulting from the achievement of universal vaccine coverage targets for these vaccines could prevent an additional 40 million episodes of antibiotic-treated illness. So the data that we saw initially on pneumococcal conjugate vaccines focusing on higher income countries clearly translated in South Africa to lower and low middle income country geographies. And then this broader analysis of antibiotic treated illnesses across low middle income geographies appears to underscore these very findings. If we shift now from rotavirus now to typhoid fever, what we see on the left is the percentage of fluoroquinolone non-susceptible cases of typhoid fever that would be that are currently affecting the globe. And geographically, you see that this burden of disease is very much concentrated in sub-Saharan Africa and South Asia and Southeast Asia. And on the bottom is the percentage of multi-drug resistant cases of typhoid fever as well. Similar geographies that have been affected. In the after the introduction of a typhoid conjugate vaccine in these geographies, what these investigators from Yale University and a consortium of other investigators estimate is the percentage of fluoroquinolone non-susceptible cases of typhoid fever that would be averted. And you see that across the board in multiple countries, this percentage of cases that could be averted due to the introduction of typhoid conjugate vaccine exceeds 50% in most of these geographies. And this is similarly seen for the percentage of multi-drug resistant cases of typhoid fever that also would be averted in the introduction of a typhoid conjugate vaccine. What remains to be seen and what needs to be followed up now is how do we actually measure the reduction, and do we see a significant reduction in antibiotic use that are concurrent with these reductions or estimated and anticipated reductions in drug-resistant and multi-drug resistant typhoid fever. Let's shift now from thinking about these bacterial pathogens for which there are vaccines to actually broadening our scope to look at viruses. So when we think about AMR, of course, our primary concern becomes bacterial AMR, but antibiotic use is not driven solely by bacterial infections. And we know that viral infections, especially respiratory viral infections, can readily cause and lead to antibiotic prescriptions, in addition to the example of rotavirus that we've just recently discussed. So when we look at universal influenza vaccine programs and the potential impact of influenza vaccination on antibiotic prescriptions, a great example is the universal influenza vaccination program in Ontario province of Canada. So in 2000, Ontario province introduced free universal seasonal influenza vaccination. And what they did was compared the rates of respiratory antibiotic prescriptions before and after this universal influenza vaccination program in Ontario province compared to other provinces where there was influenza vaccination available, but it was not free universal influenza vaccination like it was in Ontario. And what you see very, very dramatically here is a 64% reduction in antibiotic prescriptions compared to the other provinces. And if the influenza was prevented, we know that there's also a decreased likelihood of secondary bacterial infections, including bacterial pneumonia, as well as otitis media. And we see this concomitant reduction in antibiotic prescriptions and antibiotic use. A similar analysis of influenza vaccine on antibiotic use was conducted and looking at actually the mean number of antibiotic courses given to children. So if the Ontario example was focused on the whole population, this analysis from Finland is looking at influenza vaccination and a comparison of a history of recurrent otitis media during the 6-month study period. And what they see here, again, is a 13% vaccine effectiveness just against antibiotic courses prescribed among those who were vaccinated compared to those in the control arm who had not received a vaccine for acute otitis media. So we know not only are we reducing influenza, but we're also seeing a reduction in these secondary bacterial infections and therefore seeing a reduction in antimicrobial use. If we shift our attention from influenza to actually measles vaccine, we don't often think of AMR and measles in the same sentence, but there have been older data actually looking at the association between earlier measles vaccine given at 6 months versus 9 months and subsequent antibiotic treatment. And those who had early measles vaccine had a reduction again in antibiotic treatment for early versus those who did not receive early measles vaccination. So this is another example of an existing vaccine where we don't often expand and think about existing vaccination programs and how improving coverage or even modifying the vaccine schedule could impact AMR and antibiotic use and antibiotic prescriptions. And then a more recent example. So in 2019, the company Novavax had released their findings of their phase 3 pivotal maternal RSV vaccine trial. So RSV, or respiratory syncytial virus, is the most common cause of lower respiratory tract infection globally, particularly in young infants, especially those in 6 months, those 6 months or younger. So the RSV vaccine was a maternal vaccine given to pregnant mothers between 28 and 36 weeks of gestational age and was intended to provide passive immunity to their newborn infants through 90 days or out through 6 months of life. And while the vaccine itself did not meet its primary endpoint to then move on to achieve licensure, the vaccine did show about 40% reduction in medically attended RSV lower respiratory tract infection, particularly seen in the first 90 days of life. What the ARVAC consortium then did is using the trial data from Novavax, who had also collected meticulously the antibiotic use in infants in the control and placebo arms of the trial, looked at the impact on antibiotic use in vaccine versus placebo arm. And you see again here that even in a vaccine that had modest to moderate efficacy, a 13% vaccine efficacy against reduction of antibiotic prescriptions in the first 90 days of life. And when they looked for all-cause antimicrobial prescriptions, and when they looked more closely at antimicrobial prescriptions for lower respiratory tract infections, indeed they saw this 16% reduction in antimicrobial use in the vaccine compared to the placebo arm. The investigators further looked at high-income settings, seen on the figure on the right and outlined in red, compared to low middle-income country settings in the first 90 days of life, and looked at the number of LRTI-associated antibiotic courses averted per 100 infants. And you see that there's an impact seen in high-income countries and an association seen in low-income countries, although indeed that confidence interval does cross 0. But if we look specifically at the first 90 days of life for all antibiotics given, even in low and middle-income countries, we do see this reduction in LRTI antibiotic-associated courses. And in particular, this impact is seen in low middle-income countries for antibiotics like cephalosporins, which are indeed at risk of overuse and resistance. So an impact seen in both low-income countries and high-income countries. And subsequent to this, we have seen more recent data from an RSV infant long-acting monoclonal antibody trial, nirsevimab, who recently released their phase 3 data and actually combined analysis of their phase 2 and phase 3 data, which similarly showed a reduction of about 20% in antimicrobial prescriptions in the intervention versus placebo arms for an RSV infant monoclonal antibody that showed an efficacy of 75% to reduce RSV disease. So we anticipate that as we see more efficacious RSV prevention products coming forward, we will hopefully see the similar trend of an impact on all-cause LRTI as well as antibiotic prescriptions and use, both in high and low-income countries. I want to shift now from vaccines that exist, like those we discussed for pneumococcus and typhoid, as well as viral vaccines that exist for rotavirus, influenza, and very late stage vaccines in clinical development for RSV, to pathogens that are of high concern for antimicrobial resistance, for which we don't yet have vaccines. And first, I want to turn to some of the surveillance data. So if we look specifically in sub-Saharan Africa, and these trends are repeated, of course, in South Asia, we see that antimicrobial resistance is increasingly seen in neonatal sepsis as a particular population of concern that are disproportionately impacted by multi-drug resistant pathogens. So in this systematic review and meta-analysis of neonatal sepsis in sub-Saharan Africa, the investigators looked at over 150 studies representing over 84,000 neonates from 26 countries and compared two different periods, an earlier period from 1980 to 2007 to a later period from 2008 to 2018. There were 70 studies with blood culture data, and the majority of the studies were from urban tertiary facilities. And what you see in gram-positive organisms, not surprisingly, Staph aureus and group B streptococcus as the leading etiologies, and in gram-negative sepsis, Klebsiella and E. coli. What is also striking is that resistance is much more, was evaluated in the later time period, and we see a high prevalence of resistance to beta-lactams, 68%, a high resistance to aminoglycosides, and we know that these trends are actually replicated and even more striking in South Asia, where not only do we see a resistance to beta-lactams, but actually increased resistance to cephalosporins and even to carbapenems. So we know we are dealing with a global epidemic of multi-drug resistant gram-negative sepsis in neonates that is associated with an excess of mortality. Of the organisms, the one that seems to be leading the pack consistently across geographies is Klebsiella pneumoniae, and these are data from the GARD-PES neonatal observational cohort study conducted in over 13 countries and almost 20 sites, which included sites in India as well. That Klebsiella pneumoniae was the leading etiology of neonatal sepsis and related deaths after the first 24 hours of life, and was indeed associated with a high mortality, over 20%, and that compared to other organisms and when no organism was detected. In other surveillance platforms, including the Child Health and Mortality Prevention Surveillance platform that we at the Foundation support, looking at etiologies of death in children under 5, Klebsiella pneumoniae accounts for over 40% of infectious deaths in neonates in the first, in between days 2 and 28 of life. And so this is why at the Foundation we have now prioritized Klebsiella pneumoniae as a vaccine of interest for a vaccine development strategy. And in particular, again, given the preponderance of infections we're seeing in neonates, we're targeting a maternal vaccine strategy. And so here we're looking at Klebsiella pneumoniae's capsular and subcapsular antigens, of which there are over 77 capsular antigens and over 8 distinct subcapsular O antigens. And our early vaccine discovery strategy is now trying to understand the seroepidemiology of capsular and subcapsular antigens in neonatal sepsis in low and middle income country geographies to then inform our vaccine immunogen design, which we anticipate being a high valency conjugate vaccine approach. Of course, we're still very early in our Klebsiella vaccine development strategy, and we will need to first demonstrate that antibodies targeting these capsular antigens can indeed confer protection in a maternal immunization model, which is what we're working on over the next, currently and over the next 12 to 18 months, we hope to generate these data. But this just shows that even for these high priority AMR pathogens, like the 6 pathogens that are associated with close to 1 million AMR attributable deaths, there is a prospect of thinking about vaccine strategies that could potentially impact both a resistance as well as, of course, what's driving our overall interest, which is reducing mortality. So what we are currently investing in is, again, as I said, a WHO technical roadmap that now expresses priority actions aimed to strengthen the role of vaccines against AMR. This includes evidence generation, systematically incorporating AMR reduction into decision-making for currently available vaccines, as well as future vaccines, and systematically incorporating the estimation of vaccine impact into decision-making for AMR control strategies. So this is really a crosstalk between the vaccine decision makers and those who are actually focused on antimicrobial resistance, and recognizing in both arenas that vaccines can play a role for AMR, and AMR should really be part of decision-making for vaccine policy and vaccine development decisions. WHO, as I mentioned, should be coming out soon with this vaccine value attribution framework to prioritize vaccines for AMR, which would support decisions both at the vaccine development stage as well as the vaccine's use stage. And importantly, the scope of this value attribution framework goes beyond the WHO AMR priority list of pathogens to include additional bacteria as well as viruses, for which vaccines, as we saw earlier, can have an impact on antibiotic use and ideally ultimately resistance. And as I mentioned, we have had this partnership, very productive partnership with the One Health Trust, who through their consortium have estimated and quantified the potential impact of vaccines on antimicrobial resistance for a number of pathogens, some of the data of which I shared earlier in the presentation. And what we're moving to now is a partnership with the One Health Trust that is now shifting the data from a global level to moving towards advocacy at the country level and focusing on 12 low and middle income countries where the data on vaccines and AMR can be focused more at the country level to bring forward the decision makers both in the AMR as well as immunization policy circles, such that these data become the genesis of more fruitful discussions about how AMR can guide vaccine policy decisions and how vaccines can be incorporated into antimicrobial resistance national action plans. And on that note, when we look at, and then this slide is courtesy of our colleague at WHO, when we look at vaccines that and how vaccines are included in AMR national action plans, an analysis conducted by a group called Nivelle in the Netherlands looked at 77 national action plans to measure how many of these plans actually mention vaccines. And it's about 87% that mention vaccines, but only 43%, 43% have developed indicators to capture the role of vaccines against AMR, and 10 national action plans don't mention vaccines at all. We do know that that in the guidance from WHO on global guidance on national action plans for prevention of AMR, immunization coverage, and targeting some key priority vaccines, including pneumococcal conjugate vaccines, rotavirus, and measles-containing vaccines, for which we saw data on impact on antibiotic use earlier, are included as key targets for immunization agendas, but also can be included in AMR national action plans. So there is definitely room for improvement in how we consider vaccines as a tool in the AMR circles themselves. So in summary, I want to say that vaccines, we believe at the Foundation, vaccines are a central pillar and really have much to contribute to the fight against antimicrobial resistance. Current vaccines like pneumococcal conjugate vaccine and typhoid conjugate vaccine have been shown or are projected to show a reduction in both antibiotic-resistant infections as well as antibiotic use. Viral vaccines such as those to prevent influenza, rotavirus, and RSV have all been demonstrated to reduce antimicrobial use, and this should be part of the decision-making process for whether these vaccines make sense for introduction in a country by vaccine policymakers, and the impact of these viral vaccines on antimicrobial use should be taken into account by AMR policy and decision makers. Vaccines against largely susceptible bacterial pathogens like Group B strep and Group A strep, which we didn't talk about in detail in this talk, are also have potential to reduce antibiotic use. And we clearly need progress for key AMR pathogens. I highlighted Klebsiella, but others, including tuberculosis, Staphylococcus aureus, and gonococci, are high on the list of priority for vaccine development that have potential to address and reduce resistant pathogens as well as antimicrobial use. The cost benefit of a focus on vaccines to reduce antimicrobial resistance is also a key priority for WHO, as we know that countries, when they're making decisions for their AMR national action plans, will have to weigh the relative cost benefit of vaccines versus other approaches, including stewardship, infection prevention and control. And we would hope that the pie is large enough to support all of these important prevention agendas. So with that, I would like to thank you very much for inviting me to speak and share our thoughts with you and for your attention. I want to acknowledge my colleagues at the Gates Foundation, in particular Keith Plugman, who leads the pneumonia team and is my director, as well as our deputy directors in our pneumonia team, Kristen Savage. As well as key colleagues at the One Health Trust, directed by Ramanan Lakshminarayan, and at the WHO in the Immunizations, Vaccines, and Biologics group, Matthias Agopsowitz, who is leading a lot of the AMR and vaccines work. And of course, and not on this slide, but our AMR colleagues at WHO as well. Thank you once again for your attention, and we hope to continue this dialogue on the importance of vaccines to address AMR. Thank you.
Thanks everyone for your patience. Let me introduce our second speaker. Our second speaker for the day is Dr. Jyoti Joshi. He's an AMR advisor at the International Center for AMR Solutions, that's ICARS, and is based out of Copenhagen, Denmark. Dr. Joshi is a physician with specializations in community medicine from the Lady Hardinge Medical College, India, and infectious diseases from the London School of Hygiene and Tropical Medicine. She has more than 20 years of experience in Asia in research, policy, implementation areas in immunization, especially the vaccine safety area. Apart from that, she has also expertise in infectious disease surveillance and antimicrobial resistance. Dr. Joshi advocates for the need to mainstream AMR mitigation efforts within national public health implementation programs, especially in low and middle income countries. She has forged vital implementation and research collaborations for public health impact. Within ICARS, as part of the science team, she supports country teams comprising of ministries and researchers. And this combination of ministry and researchers is active in sub-Saharan Africa as well as in Asia for co-developing implementation and research projects tailored to local context, especially for AMR mitigation. With that, I request Dr. Joshi to begin her presentation. Let me just make you the co-host so you can share your slides with us.
Thanks, Ruturaj. So hello, everyone, and thank you for participating in today's webinar. I will take a few minutes, around 20 to 24 minutes, to share my slides, and then I look forward to having a discussion with you on the potential of innovation in the AMR and vaccines agenda. I still don't have access to share screen, Ruturaj.
Yes. Will it be better if I share your slides?
Okay, if that's not possible, then please share.
Yeah, okay. And I would like to acknowledge Dr. Joshi agreeing for this talk on a very short notice. I'm really thankful for that. And she also graciously agreed to tackle the Q&A at the end of this joint session. And thank you again for that, ma'am. And let me just quickly share your slides. And I would request everyone at the end of talk to just turn on their cameras for just a couple of seconds for a screenshot for our internal documentation. Yeah.
It's great. Everybody's turned on their videos now. So probably we can take a snapshot if everybody does that and then proceed to a discussion. It also helps me to see faces and, makes it a more real life experience.
Thank you, everyone.
You have to give us a timer, Rituraj, so that we can smile.
Okay, okay. Smile, please. 1, 2, 3. And I move to the next panel. Yes, 1, 2, 3. Smile, please. Thank you. Let me quickly start sharing the presentation.
So as he's sharing my presentation, maybe I'll take a few minutes to give you an overview of how I will talk. I would like to start by giving an introduction about ICARS, where I work, and then take on the topic from what has already been presented to you by Padmini. So I am not going to touch on the elements, just to make valuable use of the time. You are all busy people, and it's better that we discuss something new rather than duplicate. So since she has already talked about vaccines that are in the pipeline for AMR and that may have potential, so those are areas where I'm not going to touch. So can I have the next slide, please? Can I move them from myself here? No.
I will do it. It's
Sure.
easier that way.
So this is just a slide for you to understand my perspective. I am a public health specialist, as Rituraj has kindly mentioned, who's worked in program implementation for my 20 years of service. And in that, I have worked across implementation in low middle income countries in vaccine programs, as well as doing research in infectious diseases and antimicrobial resistance. So at ICARS, what we do, we are a Danish initiated organization, but now a non-profit, international non-profit. We do a top-down and a bottom-up approach. And what that means is we work with the ministries of health or agriculture or environment, because we take a One Health perspective, as well as researchers who are working in those countries to make a consortium that tackles an AMR issue, but at scale, so that it brings about change in impact terms for the communities that they live in. So we co-develop and execute projects by supporting this consortium. We have a lot of international partners, as you can see, and I would welcome all of you to have a look at our website and subscribe to our newsletter. Next slide, please. And the idea of this partnership is to supplement or complement the efforts of other donors and not duplicate them. So we work across 4 pillars, actually 5 if you look at the central pillar, which is being a trustworthy partner with all our stakeholders. Our first and second pillars are the key, where we look at developing and testing context-specific solutions for AMR. Remind you all, we don't do research which is bench research alone. We do implementation research, so it's a product or a perspective or a service that can be taken to scale for impact. And since the low and middle income country context is not tailored to usually places where the the intervention has been tried, we support the developing. Can I request everybody to please be on mute? Thank you. It's really contextualized in these countries in pillar 1, or we help translate evidence. For example, we know that stewardship for antibiotics in hospitals or farms is cost effective, but it has still not been done to scale in LMIC. So we help to translate this evidence by gathering data from these contexts and support governments to move it into policy and practice. Pillar 4 is more about targeted capacity building. And pillar 3 is about advocating for AMR in integrated public health management. Next slide, please. Today, we are a team of almost 26 people with 31 projects in 15 countries. And I must tell you, we have been initiated during COVID, so we are only 2.5 years old and still growing. Can I have the next slide? So this is basically the outline of my talk, since the value of vaccines, and I must remind you, I'll be talking in perspective of One Health. So I also mean the same issues that I'm going to raise are valuable for the animal vaccines, but a lot of the information that I get and my own experience is human health. But those issues are, standing for both sectors. Then I'll be discussing a little about vaccines and antibiotics, where and how these agendas are, what can be done to align them in terms of innovation. And what I mean by innovation, we'll talk. Then the touch points for innovation, and then what can be done in terms of taking this forward and the opportunities that are there. Next slide, please. Your slide is, your screen is not very clear. Is it only me or? Yeah, thank you. So next to clean water, there is no single intervention that has had such a profound impact, at least on human health. And if you look at One Health, it's even broader in terms of saving lives. And in animal health, also vaccines for rinderpest virus as well as for finfish production have been valuable tools. So these are the values of vaccines. And you've already heard Padmini speak a lot today. But remember, in today's context, there is also why we are discussing it is antimicrobial resistance and the hesitancy to take vaccines are the top 10 global health threats as per WHO. Next slide, please. So this topic, that's why, is even more pertinent. But before we start on, what is the value of vaccines for antibiotics, I would like to take a pause and help everybody think, how vaccines and antibiotics differ. Usually our pipeline today is of vaccines that are preventative. So they are given to healthy populations, mostly children in low middle income settings, but also adults. And now COVID vaccine is one which has gone across age spectrum. But antibiotics are usually given to people who are sick. So they already have an infection or an ongoing problem. There's a limited number of products in terms of vaccines, whereas the antibiotic spectrum, though limited, is at least bigger than that of the vaccine spectrum. Vaccines work through the immune pathway. And so they have limited targets because technologies have to be used to target the pathogen in a healthy individual and provide protective immunity. So vaccines are usually biological products with very sensitive and specific requirements for both production, transfer, and administration. So they require cold chain, and since it has been an integral part of immunization has been an integral part of primary healthcare delivery systems, at least in human health, they have established programs for delivery, either through primary healthcare or through the hospital clinics. Antibiotics, on the other hand, affect the different spectrums of the pathogen physiology. So they have a broad spectrum or a narrow spectrum. As we talk about the antibiotic pipeline drying up, this is something we must be mindful of. But overall, they are chemical products, so they are less prone to administration error. Their storage and transport is now not that much of a headache. And the challenge is they don't have a very standardized system of procurement. So it could be facility-based, private sector, tertiary facilities, primary facilities would have different ways of accessing antibiotics. And in fact, in many countries where we have inequity, it's very individual focused. So there is not a structured system for obtaining it other than the person who's sick getting it for themselves. Next slide. Why we are discussing this is because these are the touch points for innovation that we will come to. Oh, I had a very nice animation here, but because of the PDF, we've missed it. But anyways, so if you look at this picture, you will see that we give a vaccine. I think I can move my cursor if that helps. We give a vaccine to a group of people, and when they get the vaccine, there was an animation. I think some of these people would get the vaccine. So not everybody gets the vaccine. Then some of them would, even after the vaccine, fall sick and go down, fall into that net. So what do we need data on to assess the benefit of vaccines for antimicrobial resistance is a good data site, this gather data perspective about different information. And where will this gather data happen? It will happen at the clinical sites. So this sites from the clinical perspective will need data on the person, so their demographic data, as well as the contextual data where the vaccine is being administered, the antibiotic is being given, and so antimicrobial use data also becomes important. And the story does not stop here, because you need to make sure that the person who is fallen sick and come to the hospital has what type of infection. Because we are talking of antimicrobial resistance, we need to make sure whether it's an, please can I request you to mute your mics, please, everybody. Thank you. So whether it's a resistant infection, which is totally drug resistant, multi-drug, single drug, or extremely drug resistant, maybe it's an infection with susceptible to antibiotics that we have, or it's actually a totally unrelated infection. But all of these become critical to understand the value of vaccines for AMR. Next slide, please. So as you are all, most of you are researchers and scientists, you can understand that both vaccines and antibiotics come through this whole pathway of discovery, then clinical trials, then their licensure, and then use. And once they're licensed, their access and their stewarded use, especially for antibiotics, becomes critical to go to the community. Now, when we talk of innovation for vaccines for AMR, we must remember that this pathway should not stop at access and stewardship. There has to, because vaccines are being given to mostly healthy people. We now have talks of therapeutic vaccines, but otherwise they're mostly prophylactic. And antibiotics are being given to sick individuals. So, there is an interplay of people who become sick, then become healthy, vaccinated people who have immunity and then fall sick. So in all of that, what is the uptake issues at the field level? That feedback loop is very essential for us to make sure that we are able to innovate in assessing the value of vaccines for AMR. And I have put a highlight here in animal vaccines. There has been a big success story because especially the rinderpest vaccine has been useful because of having a DIVA strategy, which is it is able to distinguish between those who are vaccinated and those who fall sick after it. So, that becomes critical in terms of surveillance. Can I have the next slide, please? So just a figure here to show to you that in the immunization agenda also for the next decade, there is talk of needs-based innovation, new and improved products, services, and practices. We have talked about products already. We've heard about it from Padmini, but also the evidence for their implementation and the capacity building so that we improve access to these vaccines and then can even measure benefits for AMR is critical. Next slide, please. So now I come to the idea of, improving alignment for innovation. Now, what is innovation? It's not just an invention, which is a new vaccine for a disease which we don't know or a pathogen which we don't know, but it is also improving the access of existing products through improvisation. So it's a new product, or its delivery to people who could not access it, maybe in a low middle income country setting, maybe those who are vulnerable groups, maybe when there's an outbreak, and taking this to scale so that it's not just limited in a health facility or in one particular lab where it was designed or invented, but it goes on to reach those in terms of numbers so that that effect can be measured. So this economic and social value will also have to be measured if we want to innovate. Next slide, please. So what are the touch points for innovation? If you look at assessing the value of vaccines for AMR, I have highlighted here in this chain the touch points where innovation can happen. First of all, when you vaccinate a person, you have to be aware of their vaccination status, and have a record for it. Then even if they fall sick after that vaccine, which is a clinical outcome, again, you need to have a record and a measure for it. And this is not just clinical. We need to align it with the lab data because we are talking of resistance, and the role of the lab becomes critical. So if that infection was due to a resistant bacteria or a not resistant susceptible bacteria becomes critical to distinguish. And that's why diagnostics are a key area for innovation. Besides this, remember local context and the use of antimicrobials is important to understand in both animals, if it's in farms, or in human beings as background information. And also how it, the residues live in the environment around us. We are talking of a One Health problem. So all these areas become areas for innovation. And then having that product, which we're talking of, whether a vaccine, a diagnostic, or access to be delivered at scale becomes valuable. If we want to reduce AMR in a country, for example, like India, where the burden is so high, we need to make sure that vaccines that impact AMR are reaching scale. Next slide, please. So here I give you a little overview of, points where such innovation could happen. Now, innovation for vaccines could be either a new product or a service. In terms of product, I have not used too many slides because I think Padmini has already covered newer diseases like RSV or pneumococcal vaccine, which is now universal, typhoid conjugate vaccine, because we have an outbreak of resistant typhoid in the South Asian community, then are being already used. But what are the other areas for innovation? The vaccines that we give in the vaccination program could be simplified by being just an oral delivery mechanism or a microneedle patch, which is like a skin patch. For measles, this vaccine for delivery through a microneedle patch has already been piloted, and we should see soon. But the more we get such technology, the better the access in terms of effect for AMR that we can track. In addition, so far, vaccines programs in LMIC setting have only been for pediatric. For adults, maybe a few of those who could afford it, but it has usually not been across the life course of of a person. But now with COVID, again, there's an opportunity. We've had a vaccine which was so fast tracked to get it licensed and be available to not just children or adults, but to this whole and elderly, but the whole life course. So again, these are opportunities to innovate. Besides that, in the way we provide that vaccine, it's important to have a record of their vaccination status. But there are not too many innovations in terms of how this record keeping can be improved. And this is very vital for that surveillance net to work. So the vaccine status is usually by recall in most of our family health surveys or in clinical trials. But now there is talk of digital data collection, and those digital data collections could also be mobile app based or through optical recognition of data. And there are some projects which have already been funded for improved vaccine records by UNICEF, Gates Foundation, etc. And the same innovation for record keeping can be used for capturing data on clinical outcomes through health facilities, health workers, and antimicrobial use, because that is an essential element to understand what change is happening for AMR, either at the individual level or at the population level. Next slide, please. The other innovation, when I showed you the touch points for innovation pathway for understanding the value of vaccines for AMR or bringing the agendas, is diagnostics. Because unless you're able to make sure that it's the infection in a person who's been vaccinated or in a country with a high coverage is resistant or susceptible, the value of the vaccine cannot be measured. So quality assured data that can link both the phenotypic elements as well as the genotypic elements of microbiology related infection would become very critical. The current AST profiling is all done on either manual data or very expensive automated diagnostics like the Vitek device. So if we can have new devices, that would be a very vital innovation for diagnosing resistant infections. There is also a lot of focus on molecular methods. Again, post-COVID, that's an opportunity where genomic surveillance, which can use the resistance genes as tracers across One Health, could be a very useful methodology. There's a lot of technology that needs to be used, like microfluidics, nanotechnology, etc. But, and reverse vaccinology. I have a slide in the next one to show you, but all of these methods are vital to be measured not just in the usual specimen, which is blood, but also new specimens like urine, stool, sputum, etc. And not just one pathogen at a time, because in real life setting, people have multiple infections, which we need to diagnose, and we are vaccinating probably against one particular disease to differentiate. So these kind of technology platforms and methods become critical. All of this research requires interdisciplinary work. So that's what I would encourage as an area of innovation, to work beyond your comfort zone in teams that are expert beyond your own skill sets. Next slide, please. So this is just a slide. Again, it's not clear at my end. Maybe it's your connection. What are the technologies that can be used for vaccine or diagnostic design? I don't know if it's clear for the rest of you, but here I have just tried to list, and today there is a spurt in technology that we have. Reverse vaccinology was able to help us, thanks, that helps, was able to help us get a vaccine. When the genome, now we have done genome typing for most pathogens, and scientists have used reverse vaccinology to use the genome, which is being recognized for pathogenicity in the bacteria, and make a tracer for it, in terms delete it or make a tracer, replace it, to give immunity without pathogenicity. So we have got a meningococcal B virus vaccine, bacteria vaccine for human beings. Similarly, in animals, it's being attempted. But all of these technologies, whether it's having a better adjuvant or a newer conjugate or reverse vaccinology, like microfluidics I was talking. So, all of this will help us to distinguish the infection in a person who has been vaccinated, and then make a case for using vaccines for AMR. Next slide, please. Those were products, but remember, innovations could be ideas or services. So these are improvisations needed in that whole discovery to use pathway. You need better clinical study designs, which are tailored at individual level or at healthcare facility level, because the randomized control design is the ideal design, but where should it be applied to an individual healthcare community, country comparison, etc. And most importantly, most of our vaccine clinical trials don't have AMR endpoints, to make a case for that vaccine, that it just doesn't decrease the incidence of infection, but also the incidence of resistant infection. We had a very wonderful slide in Padmini's presentation where she talked about the maternal RSV vaccine trial data, which was analyzed by the RVAC consortium. So, similar study where we have the data available to make AMR endpoint decisions in vaccine trials is going to be critical. Data sharing for pathogens between academia and industry is another area for innovation. And community-driven targets, which could be, but what's the community wants in terms of vaccines, not just what is led or good in terms of profit, but, for example, neglected tropical diseases are crying out for treatment, not just of therapeutic drugs, but also vaccines. Can I please request you to? Thank you. And in addition, interdisciplinary knowledge platforms. that are important to define the target product profile for a researcher is going to be critical. So real life setting is messy. It has multiple pathogens, different anti-infectives, methods, which could be antibiotics or vaccines being given together. But we need sharp, accurate scientific techniques to make sure we are able to relate these two data. Next slide, please. In addition, like we were discussing from the One Health perspective, we don't have a vaccine for the environment, remember? We are talking only of human or animal vaccines. But what happens to the resistome or the collection of, the where in the environment or in other sites? How are genes being transmitted? How are pathogenic bacteria being transmitted in the sector where no vaccine is being given? Is important to spot for understanding transmission pathways. And again, studies that are looking for value of vaccines or aligning these two agendas should be looking at innovation or measuring this resistome changes, either at ecological level or by using functional metagenomics, because presence of a resistance gene does not necessarily mean presence of resistance. That is something for some areas that still needs to be proven, whereas it is a highly correlated, but not necessarily attributable. Next slide, please. So far I have talked about products and services up to licensure. But even for those vaccines or products or diagnostic tests which are available or are going to come in, we need to make sure that they're accessible to the people who need them the most. And they're available at scale. So we need faster production. So maybe modular production sites. If the outbreak is in, let's say, one part of sub-Saharan Africa, the availability of or the reach of that diagnostic product to distinguish the resistance, or for the vaccine that prevents that resistance being transmitted further at scale, is becoming important. And there are innovations that are being tried by the industry on these aspects, but there more are needed. A rapid turnover time for the diagnostic test will improve cost effectiveness and then chances of use so that evidence-based medicine can be practiced. Obviously, all of this requires funding. So in the innovation ecosystem, convergence of funding, which is, for example, for vaccines happening through Gavi, Wellcome, and now with the UN agencies like the World Bank joining the, IACG consortium to support vaccines used for AMR, this funding is going to open up. We also need improved public-private partnership between industry and researchers, and as well as innovative supply chains. And there is talk in one of the veterinary sector articles you will see of FAO of converging supply chain systems for human and animal health. Animal farms volumes are so high compared to human volumes for vaccines. So when we are establishing cold chains, why not use them for both sector vaccines? Is an innovation. But we need to pilot and try it further. And last but not the least, digital innovations for record keeping, as we have talked, and integration of these records with existing systems. If we have a digital India happening with the Aadhaar cards being given, similarly the animals being tagged, then having a vaccination record and an antimicrobial administration record for each animal in the farm is going to be revolutionary for the farmer. And similarly, having this record for human beings is going to be vital to ensure coverage. Next slide, please. So in terms of access and scale, again, areas that can be improved to support this ecosystem for innovation in AMR and vaccines are policies and programs. So we already have, like I was telling you, established national immunization programs with their advisory committees. And now AMR national action plans are being established, but these bodies need to speak to each other. The immunization body needs to, has regulators on board, has public health institutes and researchers on board with government bodies, needs to add AMR data in label updates and health technology assessments, so that when such technologies are being reviewed for scale up at either regional level, state level, or even at a sectoral level or a group level, then this kind of assessment is available for people to review. Pandemic preparedness is already an opportunity which COVID has shown, where it was all done to scale for COVID vaccines. So similar collaborations between national regulatory authorities which allow faster emergency authorization and deployment is critical. And last but not the least, most of our own practitioners, whether they are doctors in human health or vets in animal health, may not be aware of the value that vaccines will bring to another topic of the agenda, which is AMR. And so increased interactions between researchers, academics, and practitioners, as well as the community, is essential to make everybody understand real life settings. Next slide, please. So who are the stakeholders that can accelerate this innovation? This includes everyone from pharma, biotech, the lab scientist who's making that innovation now for diagnostic or a vaccine, as well as the microbiologist who's distinguishing the infection, whether it's resistant or not. Similarly, regulators, so that there are norms for the biotech industry, as well as researchers to understand what they are licensing, what are the potential uses of their innovation. And for deployment purposes, both the healthcare facility administrator, the policy maker, and the immunization program manager or the clinician becomes very critical. All of this ecosystem requires support, whether it is a area to do pilots for or funding to do the pilot. So countries and donors have a very critical role in this. Next slide, please. So what are the key opportunities for aligning these vaccines for AMR agenda post-COVID? It's an opportunity. We've never had such a rapid deployment for across the life course. Increased efforts for vaccine hesitancy are today visible. People are worried about taking vaccines because they were fast-tracked, but there is a lot of channels available to give right information to the community or practitioners. There is heightened communications about science, it's an infodemic in the negative sense, but because of these platforms that even international agencies and WHO is looking at or FAO is looking at, the potential for reaching the vaccine or decreasing the burden of AMR through this technology is immense. There is also a lot of focus on pandemic preparedness by having resilient health systems, good supply chains, and for both not just vaccines, but also antibiotics, medicines, and diagnostics. And the rapid and simultaneous licensure of a vaccine like COVID for whether it was India or Europe, is something that is we need to capitalize on and continue further. This all will help us for faster rollout, improving supply chain. Like I talked about the industry having new technologies, there are also discussions about opening new sites for manufacturing so that no continent is without access to antibiotics or vaccines. Next slide, please. So this is just as I close, a slide to also remember, though there are opportunities, there are also challenges and differences which we must be mindful of, whether we talk of vaccines for human health or animal health. Remember, farmer is looking at their animals as a resource to get, either to get money as a livelihood. So for him, the deployment of vaccine is not just for one animal. It is for a large number of animals in the farm. The economics becomes critical. And there are competing priorities in both the sectors that need to be looked at and the silos that we need to manage if innovation has to kick off. So you have to be prepared as researchers to tackle all of these across One Health. Next slide, please. So in summary, to foster an innovation ecosystem that aligns immunization and AMR, remember the delivery system for both vaccines and antibiotics is similar, the healthcare system in human health or the farms in animal health. And ultimately, the aim is to have community impact, which must feed back into this research pathway. So that's why collaboration and looking at innovation, not just at the lab, but in the whole R&D pathway in terms of policies and practice networks and deployment as well as delivery is critical if we want these two agendas to come closer. Thank you. Can I have the last slide? You have my contact details for it, and I welcome you all to reach out to me for any doubts you might have, and I'm open to questions now.
Thank you, Dr. Joshi, for that wonderful talk. Let's throw open this session for Q&A segment. Everyone, please go ahead. I've seen people have been typing things throughout the talk, but I guess it's faster if you, whoever has typed it can just turn on their mics and ask away.
Hello. Hello.
Yes,
Hi,
please
I
go
can
ahead.
hear you. Maybe you can stop screen sharing and we can look at each other. Yeah, thank you.
Hello. Hello.
Yes, please go ahead.
Yeah, madam, I'm Saurabh. You hear me?
I can hear you, but I can't see you.
Yeah.
So please go ahead, Saurabh.
Yeah, madam, I'm Saurabh from ADR Monitoring Center, Ajmer, Rajasthan. And I'm actually regarding what about the Indian government scenario for vaccine, this concept to vaccine used for antimicrobial resistance community in India. And because a lot of public is to be suffering from antibiotic resistance and misuse of the antibiotic in India. So then can you brief about Indian scenario, especially for Indian scenario, to because I'm not aware about the scenario of Indian government to utilize this concept and whatever the target of in future. So I think I will try to help to public and from our program of Pharmacopoeias program of India also be contribute to the concept of this new concept also.
Sure. Thank you, Saurabh, for that question. I mean, I didn't touch a specific program for India, but India has published its National Action Plan in 2017, which was of 5 years. And now they are in the process, like most countries, to revise their National Action Plan from 22 to the next 5 years. And it definitely talks about using vaccines, the licensed vaccines for AMR. And there are a few studies, in fact, already ongoing on assessing, first of all, establishing a surveillance network for AMR in India. There is one by the ICMR network, and there is one by the NCDC, where data on resistance is being gathered. Now, what is the need is also to institute studies regarding the impact of vaccines. India has rapidly introduced pneumococcal conjugate vaccines and made it universal. Hib conjugate vaccine, which is the pentavalent, has been universal since 2015. So, 2017 rather. So many initiatives have been taken, but those are areas where research is needed. Like you saw beautiful data from the US, from Padmini, about the impact of not just in the age groups that were vaccinated for resistant infections in the US, but also in the life course in elderly, in adults, when children were vaccinated with the conjugate vaccine. So similar data is needed for India, and I'm sure the Indian government and multiple other research agencies, ICMR, etc., are looking at this area. For AMR, if you would need any more information, I would encourage you to go to the NCDC website, which has the action plan, and they publish updates on each antimicrobial awareness week. I hope that helps.
Ma'am, second question, each antimicrobial resistance alternative come to the vaccines. Each and every antimicrobial resistance drug alternative vaccine will be available in the future. For example, the TB patient, number of TB resistance for MDR patient, and in future, I think TB patient also be used for the vaccines, switch over to vaccine.
So I'll answer quickly because I think Ruturaj has also raised his hand. Is a TB vaccine is still not a reality, but yes, funding for further studies on TB vaccine have been accelerated. So you may hear soon, but vaccines are one tool against antimicrobial resistance. Many other alternatives are also being tried. And again, I would encourage you to read and stay updated on potential alternatives that can be used. Thank you.
Okay, thank you so much. Thank you.
Yeah, please go ahead.
May I have a question to ask? Yes, ma'am. Myself, Masood Ahmad. I'm a research scholar. I'm a microbiologist, medical microbiologist. My core specialization is AMR, especially with respect to infectious disease. And I thank you for very informative and enlightening presentation. The question which I had during the presentation of yours is the bioconjugation, which you are talking about. and this resistosomes. Ma'am, can you enlighten us on that? Because we are talking about vaccines, and meanwhile there's a lot of work which is going on bacteriophages as well, to tackle the AMR. So what is your thoughts? Because I had texted as well in the chat box regarding the collaborations, because we are very much interested to go in deeper to explore the AMR as well as with respect to the bacteriophage. And when you talked about this bioconjugation, I got quite questions in my head. I thought it must need to be addressed.
Great. Thank you, Masood, for your question. Your name reads as Ruturaj, so I was confused.
Yeah.
So 2 points. I mean, today the focus of my talk was aligning vaccines and vaccine and AMR agendas together. So I have touched on the areas where innovation can happen, but not definitely gone into the depth of each. So bacteriophages are an alternative mechanism to address AMR, which is like instead of antibiotics. So it could be a therapeutic intervention, whereas vaccines here, we have been mostly talking of prophylactic ones. I must qualify. So I have not touched bacteriophages. I would encourage you to go and read about it. Coming back to the other point you asked about bioconjugation. Now, again, I must qualify, I am not a bench scientist, but I have given some links for the articles in my presentation, and I would encourage you to read about them. There are new technologies that even the vaccine world is trying to address to get vaccines for newer targets, like we were talking, or having them delivered to targets to become more efficient vaccines. So in that bioconjugation, where instead of is a technology, like I elaborated a little on reverse vaccinology, but in bioconjugation, instead of using, you use a conjugate for the pathogen part that you want to deliver to develop immunogenicity rather than have pathogenicity. So this has been tried, not necessarily to scale, but it is still in a clinical trial phase where for some vaccines it's been tried, and that's why it's an innovation which can be used for understanding its value, because it will have potential impact on the infectious disease transmission.
If I may ask one more question, if I have opportunity.
Moderator.
How about someone else? And then if you have time, we can come back. Or you can always email me. That's fine.
Sure. No problem.
Feel free to write to me.
Yes.
Sorry, I didn't took your email. Sorry for that. If you share one more time, I can take a screenshot of it.
I'll put it on the chat. Don't worry.
Yeah. Thank you.
Yeah, I think so. The reminder link that I shared has led to many Ruturajas. I apologize for that. So the other Ruturaj who has raised the hand, please go ahead and please introduce yourself. Yeah. Okay, somebody has raised their hand. Please go ahead.
Yeah, may I ask? I have a question. Hi, I'm Baizid. I have a question to Dr. Joshi. I mean, first of all, really compliments for your lecture. It was very informative. So one area, ma'am, you highlighted is vaccine as a national action plan on AMR. So can you throw some light onto it? Where to start with, because today the acceptance overall in the developing countries is something, vaccination is especially in the adult section, it's been not widely accepted. So vaccination AMR.
Sure. Thank you for your question. Yeah, thank you for your question. What I will suggest is you must look at the national action plan that India has on its website. One of the areas for the country's action plan is research and development. So as part of that, for example, today you are all part of a webinar which is done by a biotech accelerator consortium, if I may, Ruturaj, for CCAM. So, you know, which is getting entrepreneurs and researchers and epidemiologists or public health persons like me talk on a platform which is outside our disciplines. So the idea is to first develop, you must as a researcher, the advice I can give you is develop a network or a collaboration with interdisciplinary groups, so that it's not just the lab. When you talk to the real life setting, when you talk to an engineer, he has perspectives of how probably the biotech area that you are working in, it could be antibody, bacteriophage, or vaccine agent that you want to deliver could be available to provide immunity, how it can be measured. And then when you talk to the community, you will get to know that what is the problem for the community for which you can try an innovative solution. Now, such discussions or such collaborative networks will give you ideas, and the ideas will then need some support, for which you need funding. So that collaboration could be within the country or outside the country. You have consortiums with like-minded researchers, read up on the topic. And then when you write your calls or your thesis or your partnerships together, those are the opportunities where you will be able to understand where, if it's a research idea, then it needs to be done at the lab. If it's a real life setting, then you can do it in the community by asking the community of what type of vaccine they would like to have, and then coming back to the lab and discussing whether it's possible to have that kind of vaccine, and then measuring its effect in terms of resistance. So it's not a straight path. It's not a path that has been walked on by before. And it's not like the traditional research probably 20 years back, when the most of the research would have been done in developed world, and then that vaccine or antibiotic would come to India. So that data and that experience is useful when we do it in a new setting. So now you are working at the same time as another researcher in a developed world. So develop that collaboration, think out of the box, and go out of your comfort zone, but come back and reflect. I think those are ideas that will help you accelerate innovation for AMR.
Thank you so much, ma'am.
Can we have one more question and then call this session? Anybody?